This is a brief commentary on common pain patterns that lead to a diagnosis of sacroiliac joint dysfunction. I actually prefer terminology such as sacroiliac syndrome, and one of the problems is that a lot of these pain patterns or behavior signs and symptoms are very similar to signs and symptoms of lumbar facet pain, any of a number of lumbar spine dysfunctions, and same for the hip joint. And injection studies show that as high as T12 and all the way down to L5 and S1 can refer pain to the region overlying the sacroiliac joint. So someone pointing to the PSIS, pointing to the region of the SI joint, is not an absolute indicator. There was one study done by a physician named Dr. Fortin, F-O-R-T-I-N, and he named that the Fortin finger test, and basically showed that if someone points there, then that's going to correlate well with pain relief with injections in the sacroiliac joint. On the pain drawings, they tend to mark areas below the level of L5, but it's a difficult thing to state that there are absolutes in terms of how a sacroiliac joint dysfunctional pattern will present. Much of the pain can be mediated with soft tissue in the region of the sacroiliac joint, but even the iliolumbar ligament can be a pain generator that will affect pain in that region. And it is so functionally integrated with the lumbar spine that cutting the iliolumbar ligament also increases mobility within the sacroiliac joint. So within the workbook, I do cover signs and symptoms of dysfunction, but I certainly urge caution. The approach that we cover here is more of a biomechanical model than an absolute strict pain model, and we certainly cover that pretty thoroughly in other sections where we talk about some of the problems with using injection in the joint and then jumping to the conclusion that that means that the joint itself is the generator of pain. In our workbook, we cover a small section called Signs and Symptoms of Dysfunction. And again, these are going to sound very similar to other patterns in the hip and lumbar spine. Antalgia is not uncommon. Pain with sitting is a common complaint. The subjective reporting of inability to sit squarely on the sit bones or ischial tuberosities is another complaint. Oftentimes rotational movements may be symptomatic, such as turning in bed, and pain can be in the region of the PSIS or medial or inferior, can radiate down the buttocks, sometimes down the posterior thigh, but has a distinct different quality than sciatica. Unless proven otherwise, I believe it's a very safe assumption that sciatica is not caused by the sacroiliac joint. I think it's best to perceive that as being a lumbar phenomenon. And of course there are a few extreme examples, such as an unresolved hematoma in the hamstring muscles or within the region of the piriformis, putting pressure on it. The diagnostic process needs to be thorough. And clients will also report pain radiating towards the trochanter, posterior and lateral, and some will point to pain radiating medially along the inguinal region. And certainly there are other lumbar patterns that create these these pain referral patterns, and there are hip dysfunctions that create them as well. Favorite thing that people say is that they have a hitch in their get-along. They feel like something in the pelvis mechanically is preventing them from functioning. Weight bearing will sometimes be uneven if you have them stand on two scales. They may feel an increase in clumsiness. They might feel that the leg gives out from under them, which might be an acute onset of pain. And the persons who have had bone harvesting from the iliac crest region, very possible that they have developed instability in response to that. People who've had lumbar fusions with bone harvesting, that population may be prone to a true sacroiliac joint mechanical dysfunction or ligamentous inadequacy. This patient population typically has had a very thorough workup and multiple tests being negative. Common with a fall onto the buttock, a step off a curb, a twist involving a fixed foot, lifting injuries, car accidents, especially when they're using one leg against the brake when they're rear-ended or have an abrupt deceleration. We certainly know that the population who's had a pregnancy or even particularly those with a difficult pregnancy or difficult delivery may have chronic sacroiliac joint mediated pain. We see some cases that present with pain in this region with several of these signs and symptoms after undergoing a surgical procedure, and I think we need to be reminded that the person is being prepped, is being positioned in a safe position with sandbags or straps applied. Their protective mechanism via anesthesia is tamponed way down, and so people are transferring them from gurney to bed, etc., and that can impart some passive stresses to the structure. And I like to perceive the sacroiliac pain syndrome as nearly always accompanying some dysfunction in the hip, some dysfunction in the lumbar spine. Certainly very relevant to screen both of those. And then I want to look at a recent book on surgical approaches to the painful dysfunctional sacroiliac joint. Just make sure that I'm being thorough. And certainly a previous pelvic disruption from a motor vehicle accident, a severe trauma, a fall from a significant height, painful delivery, that can also correlate very well. People with inflammatory arthritis can present with SIJ pain. And certainly a leg length difference can alter stresses going through one side of the body, particularly those that are greater than or equal to 3/8 of an inch, per some very good research done in the early 80s. And I think that provides a good background in discussing a somewhat classical presentation of the pain presentation with SIJD, but again, that cautionary note to realize that oftentimes other things are going on and it can mimic lumbar and hip presentations. Thank you.